Welcome guys to my another video today. We're talking about the anti-muscarinic agents. Remember, we have the muscarinic agent, which means they bind to the muscarinic receptor. But this one, we're talking about the anti-muscarinic agent because they prevent the binding of acetylcholine to the muscarinic receptor. So that's what we are talking about, because this video is under the classification of anticholinergic agents. For anticholinergic agent, you have the anti-muscarinic and you have the anti-nicotinic agent. So the antimuscarinic prevents binding of acetylcholine to the muscarinic receptor, and the cholinergic blockade too, or the anticholinergic drugs, are the drugs that prevent binding of acetylcholine to the nicotinic receptor. So this one will just be focusing on the antimuscarinic agents and what are they. So we can also call them the muscarinic receptor blockers. We can also call them the muscarinic receptor blockers. And what is their work? They prevent acetylcholine from binding to the muscarinic receptor, thereby inhibiting the parasympathetic action on the organ we are binding to. So don't forget. So they are also called parasympatholytic drugs. So remember, the cholinergic drug which we talk about, or the cholinergic agonists, are called parasympathomimetic. Why this one is called parasympatholytic drug? So which means they inhibit parasympathetic action. Don't forget. So it will just be simple and go straight to the point, because I want you to get it. So I divided cholinergic agonists into direct and indirect. So this one, now we are divided anticholinergic into what? Antimuscarinic and antinicotinic. Don't forget. So in this video, we are specifically talking about the antimuscarinic agent. So what is the classification of the antimuscarinic agent? So the antimuscarinic can be divided into the natural alkaloids, synthetic and semisynthetic derivative. Natural alkaloids, synthetic and semisynthetic derivative. Don't forget. So we'll be talking first about the natural alkaloids. Under the natural alkaloids, we have atropine. Don't forget, atropine. And we have what? Scopolamine. Atropine and scopolamine. Don't forget it. Well, under the sympathetic, we group them into what? Myadratic drug. We group them into antispasmodic drug. We group them into bronchodilators. We group them into what? Anti-Parkinsonian drugs. We group them also into what? Urinary antispasmodic drugs. So that's how we are grouping them. So we are grouping them based on their action. So remember, in the cholinergic agonist, we want this action. We want the parasympathetic action. But in this one, when the action is now too much, how can we counter the action? That's what we want to talk about in this agent. So what is atropine used for? So we are going straight to the point, because in my subsequent video or my next video, I'll be basing on this drug so that you will know them personally. So but this one, I want to give you a rundown of all the drugs now. Atropine now, it's a prodrug used in bradycardia. So when patient has severe bradycardia caused by acetylcholine binding to the M2 receptor, especially the SA node, because when acetylcholine binds to the M2 receptor, what happens? It causes hyperpolarization, and hyperpolarization will do what? Decrease the heart rate. And once you decrease the heart rate, what happens? You decrease the blood pressure also. Decreasing the heart rate, decrease blood pressure. You can also reduce the stroke volume. So when you decrease the stroke volume, you reduce the cardiac output. So excess reduction of cardiac output, you decrease the blood volume. So it's very, very easy. So we can have what? Bradycardia there. So it can be used to treat what? Bradycardia. And this bradycardia is also used as an antidote for what? Organophosphate poisoning. So two things. It is used to treat what? Bradycardia. Also, because when you treat bradycardia, you increase the heart rate. When you increase the heart rate, you can increase everything immediately. So when you treat bradycardia, you can work on all cardiac parameters. Also, it's used as an antidote for what? Organophosphate. Don't forget, pyridoxine and atropine are used to counter what? Organophosphate. In my last video, I taught you that. So after atropine, you have scopolamine. So scopolamine is very easy. Scopolamine is targeting what? Motion sickness. For those that during climbing or mountain, they feel dizzy due to a fall in blood pressure, or for those that when they are traveling a long journey, they tend to be feeling this nausea and vomiting, ability to feel uneasy in the bus, or when they are flying, they feel this uneasy. So it's used to treat motion sickness, and it's also used as an antiemetic drug, helping to prevent what? Nausea and vomiting. So under the natural alkaloids, you have the atropine and you have the scopolamine. Now under the synthetic drug, I told you have myadratic drugs, because now when you have excess meiosis caused by what? Cholinergic agonism. What is meiosis? When the acetylcholine bind to the what? M2 receptor. The M2 receptor are present in the what? Sphincter papillae. So where is the sphincter papillae? The sphincter papillae is present in the pupil. So when acetylcholine bind to the empty receptor in the pupil, what happens? It will reduce it. So when it reduces it, it causes you to see far vision. It causes what? Far vision. So it makes you see very well, meiosis. And when you're having meiosis, you are also constricting the what? Ciliarus muscle. So what is ciliarus muscle helping us to do? It's helping us for accommodation. So when you are contracting the ciliarus muscle, you are also reducing what? Intraocular what? Pressure, because you are allowing the flow or the drainage of what? Aqueous humor into the what? Canal of Schlemm. So don't forget. What is it used for? The first one is now with the myotic agent. So when you remember myotic agent, you are remembering that they help to cause what? Myosis, which is to counter what? Meiosis. So meiosis is when they bind to the empty receptor in the sphincter papillae. So when you have the sphincter papillae, it helps you to reduce the pupil. So myosis is a cause when they bind to the what? Dilator papillae. So there are two parts in the pupil. You have the sphincter papillae, which reduces the pupil, and you have the dilator papillae, which what? Increases the pupil. So they have three different nerves that is acting on them. So the first one, the one that give innervation to the sphincter papillae is the what? Oculomotor nerve. Don't forget. So the oculomotor nerve helps to give nerve fiber to the sphincter papillae, causes meiosis. So the ophthalmic division of the trigeminal nerve innervate the what? Dilator what? Papillae. So dilator papillae helps you to open the pupil, causes what? Myosis. While the sphincter papillae helps you to reduce the pupil, causing what? Meiosis. Don't forget. So we want to counter meiosis, so we give the patient what? Myotic drug. So it's an eye agent. So the two drugs under this classification is what? Tropicamide and cyclopentolate. Don't forget. Tropicamide and what? Cyclopentolate. So tropicamide is a short-acting myotic drug. It's also used to treat what? Cycloplegia for eye examination. So you use it to causes myosis and cycloplegia for eye examination. So tropicamide short-acting. So if you want to counter the short-acting, if you want to use a long-acting agent, you use what? Cyclopentolate. So cyclopentolate is a long-acting part of what? Tropicamide. So that is when you want to widen the eyes for patients with excess what? Meiosis, because excess meiosis is not good. It's not good. So when you have excess cholinergic effect, you are having meiosis. And if you want to counter meiosis, you either use tropicamide or cyclopentolate. Both of them, the only difference is that cyclopentolate has a long action, while tropicamide has a short action. Another synthetic agent we're talking about is antispasmodic drugs. What are antispasmodic drugs? They inhibit what? Spasms. They don't want spasms. They don't want constriction. Because remember, when you bind to the M3 receptor, you allow constriction. And when you are contracting too much, what happens? In the GIT, what happens? You increase what? Peristalsis, and that can cause diarrhea. In the bladder, when you contract too much, what happens? It causes enough urination, which means the patient will not be retaining water, which means it will cause dehydration. So you don't want excess spasmic what? Activity. You want them to also contract and also relax at the same time. So it is used to counter any what? Spasmodic what? Activity, especially in the GI and the urinary tract. So what are we? So we are using dicycloamine, which is used in treatment of irreversible bowel syndrome. It is used in what? Irreversible bowel syndrome. So the first one we are using is dicycloamine, which is used in what? Irreversible bowel syndrome. Don't forget dicycloamine, irreversible bowel syndrome, like diarrhea. So when you have diarrhea, GI cramps, bloating, you can use your dicycloamine. Also, you have hyoscine butyrate. Don't forget hyoscine butyrate. First one is what? Dicycloamine. Second one is what? Hyoscine butyrate. You can also call it Buscopan. So this is the brand name. The brand name is Buscopan. So when you go and buy Buscopan, what is Buscopan action? So Buscopan helps you to reduce GI or spasms, because excess GI spasm increase motility and secretion, and you don't want excess motility because it will cause diarrhea. So dicycloamine and Buscopan is used to reduce GI motility and also biliary and renal colic. So what's biliary and renal colic? So when you have stones in the GI tract, so it helps you to what? Reduce all this stuff. Also in the bladder, so when you have excess contraction of the bladder, you can also use Buscopan or dicycloamine. The next one is our bronchodilators. So what are bronchodilators? Bronchodilators, they have also what? Dilate the bronchus. Remember, when acetylcholine binds to the M3 receptor in the bronchus, what happens? It causes bronchospasm. Especially when you use drugs like methacholine. Remember, methacholine binds to the M3 receptor, causing what? Bronchospasm, which we use in what? Diagnosing what? Asthma or COPD. So we call it bronchoprovocative what? Test. The bronchoprovocative test is used to diagnose what? Asthma, where we use what? Methacholine. So other cholinergic agonists can also constrict the bronchus. So if I want to counter bronchoconstriction caused by any cholinergic agonist, what will I give? I'll give a bronchodilator. So under this classification of antimuscarinic agent, What are the bronchodilators? The bronchodilators are Ipratropium and what? Tropine. Don't forget, Ipratropium and what? Tropine. So Ipratropium and tropine, the only difference here is the duration of action. Ipratropium acts for a short time, tropine acts for a long time. Don't forget, Ipratropium for a short time, tropine for a long time. So both of them are bronchodilators. The only difference is that they act their duration of action. So if a patient if you want to treat a patient for a short time, you use Ipratropium. If you want to treat a patient for a long time, you use what? Tropine. So tropine is used in the maintenance phase, to use to maintain a patient for a long time. So starting for a long time, okay, patient that have asthma or COPD now, you want to start a treatment, you can start the patient on tropine, which is for a long time. Then you wean the patient with Ipratropium, so which is for a short time. So you start with tropine to maintain the patient. So when you are seeing an improvement in breathing, or you are seeing an improvement where the bronchus is dilating, what happens? You switch the patient to what? Tropine. Don't forget. So because all the whole cholinergic agonists can give bronchospasm. So to counter it, you can give the patient what? Ipratropium and what? Tropine. So in the antispasmodic, don't forget, you have what? Buscopan, which you call what? Hyoscyatin butyrylbromide. Also, you can also give the patient dicycloamine to counter the effect of what? GI motility. Also excess what? Urination. So you can use it to counter it. The next one is the anti-Parkinsonian agent. The anti-Parkinsonian agent, because in Parkinson's syndrome, what happens? There's a reduction in dopamine, and dopamine helps to what? Modulate movement. So when stimulus go to cerebellum, what happens? It helps you to modulate movement, especially to know where right you are going. So if you are moving in a direction, it wants you to move in a direction, because when there's damage to the cerebellum, it gives a lesion called Parkinson's disease. So Parkinson's disease is when there's a decrease in dopamine, or there's a decrease in the nigrostrial pathway. So you go to my video on the basal ganglia and the physiology of the cerebellum. So there you understand what movement is all about. You understand how the brain controls what? Movement. In this anti-Parkinsonian agent here, you are not really managing the Parkinson's disease here, because if you want to manage the Parkinson's disease, there are other drugs which you call the anti-Parkinsonian drugs. There are various anti-Parkinsonian drugs, but in this one here, you are trying to manage the spasmic condition, because remember, majorly cholinergic effect produce spasms, contraction, excessive contraction. So what are you doing? In patients with Parkinson's disease, there's always spasmic what? Paralysis, excess spasmic paralysis, which there will be rigidity. You will not be able to move their hands. Even apart from the ataxia they are having, you will not be able to move their hand. Their hand will be very, very tight. So to reduce some Parkinsonian action like tremors, like spasmic paralysis, like so many. So to reduce all these things, you have to give them some drugs. So which are all these drugs? You can have what? Benztropine. So Benztropine is an anti-Parkinsonian agent under the antimuscarinic effect. So you want to reduce tremors and spasms, because when there's excess and contraction, what happens? Patients can present with tremors, and patients can present with what? Excess spasmic movement. So the patient limbs will be hard to move. You can give the patient benztropine and what? Dihexyphenidyl. So these two drugs, benztropine and dihexyphenidyl, can be used to counter the action of spasmic paralysis and excess tremor. So you are treating the symptom of Parkinson's disease. So if you want to increase dopamine, you go to my video under the anti-Parkinsonian drugs, the drugs used to tackle Parkinson's disease, which is they can act like a dopamine agonist, and they can also act as an indirect dopamine agonist. So you watch my video there. But in this one, we want to treat the symptoms of the Parkinson's disease, which is tremors and spasmic paralysis. So the next one is overactive bladder. Well, for patients with overactive bladder, or we can call them urinary antispasmodics. The first one is antispasmodics, which can occur in the GI tract majorly. But in this second one, you are targeting the bladder. The first one can be GI antispasmodic. The GI antispasmodic is used to target majorly the GIT tract. So excess GIT motility and secretion, buscopan and dicycloamine is used to tackle that effect. But this one we are having urinary antispasmodics, which is used to tackle overactive bladder. In this one you are using oxybutyn, which is a good agent here. This one work for a long time. It has a longer duration of action. So you are using oxybutyn, you are using toteridine, you are using derifenacin, and using sulfenacin. So you can either use derifenacin, sulfenacin, oxybutyn, or toteridine. So the only agent they use here more is oxybutyn. So they are used to reduce excess contraction of the bladder. So remember, when we are talking about the cholinergic agonist, the agent we use to increase bladder action here is Bethanical. So you use Bethanical to constrict the bladder to allow what? Urination. So don't forget. So we have done it also very, very well. So we are done with the classification. Remember, they are classified under what? Synthetic, semi-synthetic, and natural. Under the natural, you have atropine and you have what? Scopolamine. Under the synthetic, you have various ones. You have the urinary antispasmodic, you have the GIT antispasmodic, you have the anti-Parkinsonian agent, you have the bronchodilators. You also have the myotic agent. So I've explained all of them to you. So what are the side effects? So the side effect here can be dry mouth. Why? Because you are decreasing salivation. Don't forget, you are decreasing salivation, so the patient will present with dry mouth. In the eyes, since you are causing myiasis, you'll be causing what we call sand eyes. There'll be sand in, just like a sand in your eyes. You'll be having blurry vision. Why? Because you want myiasis instead of meiosis. In meiosis, you see clearly, but the only thing that when there's excess meiosis, you also have blurry vision. But here, since you are causing myiasis, so excess myiasis will cause what? Blurry vision. So now in the bladder, since you are countering the effect of what? Urination, since you don't want urine to occur, what happens? You'll be having a side effect called urine retention. Don't forget. If I am storing urine too much, if I want to promote urination, I use cholinergic agonists. So if I want to now store urine because of I have been urinating too much, what will I do? I'll give the patient what? Antimuscarinic agent. Excess antimuscarinic agent will cause what? Urinary water retention, which is a side effect when you are giving patient toteridine, oxybutyn, dorifenesin, sulfenacin. You can have what? Urine retention, excessive. So when you are giving patient atropine, excess atropine, what are you using? You are causing what? Tachycardia. Because excessive atropine will what? Inhibit M2 receptor, causing what? Tachycardia. And you don't want your heart rate to be moving too much. You get it? So constipation, when you are trying to give a patient GIT antispasmodics, so you want to counter what? Irreversible bowel syndrome. You want to counter diarrhea. You want to counter abdominal cramp. If you want to counter it, you are giving the patient antimuscarinic drug. What happens? You can present with constipation. Why? Because there will be decrease in GI motility. So the food will be moving slowly. So if the food is moving slowly, you want to go to the toilet, you will not be able to go. So that is constipation. But the side effect for cholinergic agonists is diarrhea, abdominal cramps. You get it now? So you have to put them in a tabular form, separate them from, because the side effect when you have excess cholinergic effect, to counter it is anticholinergic. So when you want to counter anticholinergic, you use cholinergic. That is very simple. So the next one is hyperthermia. So when you are increasing sweating too much, what happens? You will be hot, and when you are hot, you'll be losing water. So you can also have a side effect called dehydration. Another side effect, decrease in blood volume. Are you getting me now? So all these things are there. So when you are retaining urine, what will happen? You have pain. When you are having blurry vision, you will not be able to see well. Are you getting me now? So when you're having bronchodilation is good because you allow what? Excess air to enter into the bronchus. And if you allow excess air to enter into the bronchus, what happens? You will breathe in well. So bronchus will not have any side effect. It's only when you are constricting the bronchus excessively in cholinergic effect. You get it now? So also CNS side effect too. There are CNS side effects like confusion, agitation, especially in elderly people. So these are side effects, and we have talked about the uses already. So I hope it all makes sense to you. I hope it made sense to you and you understand everything I talked about under the antimuscarinic agent, where I said that they are inhibiting acetylcholine on the what? M1 to M5 receptor, which means we want to counter the muscarinic effect, which is the cholinergic effect. We want to counter the action of acetylcholine on the M1 to M5 receptor. So if there's excess cholinergic effect, especially on the muscarinic receptor, we want to counter it. So if we want to counter it, we use this antimuscarinic agent. So you can use the natural form, which is gotten from plants, which is belladonna plant, atropine, or you can use the scopolamine too. Scopolamine is a derivative of what? Atropine. We'll be talking about them presently in different videos. So you can use the one synthetically derived, particularly for a condition. First one, you can use the myotic drugs due to what causes myiasis. You can also use the anti-Parkinsonian drug used to treat rigidity and tremors. You can use the GI antispasmodic drug used to decrease what excess peristalsis movement, which can present with what diarrhea. You can also use the one used to treat what urinary antispasmodic, used to treat what overactive bladder. So you don't want to be urinating too much, so you counter it with oxybutyn. So you can also what counter organophosphate poisoning using what atropine. You can also counter what Parkinsonian drugs using Benztropine and hexafenadine. You can also counter what respiratory issue for patients that have excess bronchospasm. Counter it with Ipratropium, Atropine. So I hope you understand. So if you want to understand, go watch my cholinergic video before you come here. I made sure I connect it and correlate it to a cholinergic so that when you are reading it, you can understand both of them together. You get it now? So in the next video, we'll be talking about each drug so that you can understand them, where they are gotten from, and their duration of what action. Keep watching my video. Like, subscribe, and share always. Bye bye.